Okay, so good afternoon, guys. We're going to start today with acid controlling drugs, and this is going to relate to all our drugs that help with gastrointestinal issues. So we're going to start with acid-related pathophys. So we're going to start with just kind of a background. So the stomach is lined with specific glands. The middle portion are your gastric glands. These gastric glands have three different cell types. The three different cell types are your parietal cells, your chief cells, and your mucus cells. Your parietal cells are going to be your cells that produce and secrete hydrochloric acid. They're going to aid in digestion. They also serve as a barrier to infection of the gut, and also they help to maintain the pH between 1 and 4 of your stomach. The chief cells are your cells which help to secrete pepsinogen, and the pepsinogen is a pepsin, and this also helps to digest your dietary protein, so the protein that you eat or that you get from food. The pepsin is what helps to kind of digest that. Then you have your mucus cells, and your mucus cells help to secrete mucus, which the mucus serves as a protection of the stomach lining. And so this is basically your background on your gastric glands that help to produce the gastric secretions. So the walls of the parietal cells, they contain three different types of receptors. So remember, the parietal cells are one of your cell types of your gastric glands, and then the parietal cells are the ones that have three different types of specific receptors, and any of these receptors are going to help to initiate the acid production and secretion. And the receptors are acetylcholine, histamine, and gastrin. And those are your three receptors that are on your parietal cells. Some more patho. So your receptor is going to be occupied. So receptor, remember, it is going to be looking for acetylcholine, histamine, and gastrin. These receptors are going to be utilized by the body. So they are almost like messengers. The messenger is sent inside of the cell. When it's sent inside the cell, the messenger then provides the energy for the proton pump. Once the energy is present, then the proton pump is then activated, which helps then to transport the acid and the hydrochloric acid. The hydrochloric acid is then produced, which is your main acid of your stomach. And again, it's their chief cells that release the pepsin, which then helps to produce the acid. So remember, it's like a full circle. I want you to kind of get that background. Pepsin is secreted by the chief cells in response to the release of the hydrochloric acid. Pepsin is that enzyme that helps to digest the protein in your diet. Substances that stimulate the hydrochloric acid secretion are going to be things like food, and not just food like the actual food, but the seeing food, smelling food, tasting the food. All of those things related with food are going to help to stimulate the hydrochloric acid secretion. Alcohol is another. Okay, so we were at food, which helps to stimulate the hydrochloric secretions. So your sight of food, your smell of food, and your taste of food. Alcohol, and then caffeine and chocolate also stimulate the hydrochloric acid secretion. Your other gastric functions that your stomach does is also that it produces bicarbonate, and bicarbonate helps to prevent the hyperacidity. So it's going to act as a buffer in the body, in your stomach. And then it also produces intrinsic factor. And if you remember back from your med-surg, intrinsic factor is what helps to facilitate the gastric absorption of vitamin B12. So if you don't have your your intrinsic factor, then you have pernicious anemia. Remember back then when we talked about that. And then your prostaglandins, it's also produced by your stomach and your gastric enzymes, and it's also an anti-inflammatory, and it's going to have also protective functions in your stomach and in your body. So use of the acid controlling drugs. So why do we use them? So most common condition is going to be mild to moderate hyperacidity. So for most people, the reason why they're going to go to your Prevacid and your Pepcid and those types of drugs is because you have an overproduction of the hydrochloric acid, and that causes symptoms. Often it's also associated with GERD, and GERD is a reflux of the stomach acid up into the esophagus. This reflux can cause damage of the esophagus, which can lead to a precancerous condition. So you have all that stomach acid kind of sitting in the lining of your esophagus, which could then erode that lining and then cause you to be more at risk for precancerous or cancerous conditions. Stress ulcer prophylaxis is another reason why you would take these types of drugs. So we want to prevent a stress ulcer. So patients that are in the ICU are given these acid-controlling drugs to be able to prevent them from getting stress ulcers, because they're really ill patients and their body is under stress. And so your body under stress will overproduce hydrochloric acid. There's actually no research to support the continued use once the patient is transferred out of ICU. So usually, for the most part, we do continue them on these meds once they get transferred out, but there is no research to support the continued use. It's just been kind of what we've been doing in practice. Another reason is for stress ulcer prophylaxis is an H2 blocker, or a PPI, and this is going to help to block this hydrochloric acid and this and the histamine that's being produced by your stomach. So it's going to help prevent, and also because you won't have that hyperactivity or that hyperstimulation of the hydrochloric acid. We use it for peptic ulcer disease. So basically, really patients that have already been diagnosed with peptic ulcers, and especially those that have been caused by H. pylori, and your H. pylori stands for your Helicobacter pylori bacteria. For peptic ulcer disease, we use a specific treatment, and we usually do a course of 10 to 14 days of the PPI. We also give them the clarithromycin, which is an antibiotic. Also, to help treat the peptic ulcer, we use amoxicillin and the metronidazole, or a combination of PPI, the bismuth, subsalicylate, the tetracycline, or the metronidazole. So we might use a combination of drugs to be able to treat this peptic ulcer combination. So antacids. Now, when we start with antacids are basic compounds like your Tums, your milk of magnesia, those, etc., those kind of things. The mechanism of action, the way they work, is that they're going to neutralize your stomach acid, which then prevents pepsin secretion. So because pepsin is secreted due to the release of your hydrochloric acid. So if you're neutralizing the stomach acid, then you're preventing the pepsin from secreting any more stomach acid. So reasons, indications, we want to help to promote healing and relieve pain. So we're neutralizing that stomach acid because it's overproduced and it's causing irritation and inflammation of the stomach wall. So this will help to promote the healing. So we treat peptic ulcer disease with this. We treat GERD. Adverse effects that you will see, magnesium will cause diarrhea or hypermagnesiemia. So it can lead to toxicity in patients with renal impairment. So as a nursing intervention, you need to monitor for CNS depression because you may have an increase in your magnesium level, especially if you're taking a lot of Milcomag, especially that type of medication. Your albumin and your calcium will cause constipation, so you need to monitor patients for that. Hypophosphatemia, so you need to monitor your electrolytes and your hypomagnesium. So when you're taking a lot of Tums, because you're taking the aluminum and the calcium, it's going to cause your magnesium to go down. And so you really need to monitor patients' electrolytes when they're on these meds. Excessive use of these meds will cause alkalosis, and overuse or misuse and sudden discontinuation will also cause a rebound hyperacidity. So remember, it's a way of neutralizing the stomach acid. So if all of a sudden you either misuse it or overuse it, or you just suddenly stop taking it, it's going to lead to a rebound effect, and you're going to have an extra, a more hyperactive production, and you'll end up with a hyperacidity. Mask symptoms of severe underlying disease. So really, if you're masking these symptoms, it could be leading to worser disease processes. So you can't take them for too long, especially longer than 2 weeks, without getting tracked. If you start to have issues that haven't resolved in less than 2 weeks, they really need to see a primary or physician regarding that issue. They can't be meds that you take for a continuous amount of time. It can also cause fluid retention, especially for those that contain sodium. So as a nursing intervention, you want to make sure that you are watching your patients with heart failure or hypertension, and you should avoid these meds with these patients. So that is another contention point that you need to look at as a nurse. Back still with antacids. So again, we talked about that these are your basic compounds, right? Contraindications. So who do we do not give these meds to? So we don't want to give these meds to patients that have severe renal failure, again, because it will lead to a increase in magnesium, which will then lead to a mag toxicity, which then will then produce or show CNS effects and CNS symptoms that you will see. It will, you don't want to give it to patients that have already an electrolyte disturbance, so it can make these disturbances already present worse. So you don't want to give it to those patients. And then you need to be cautious with patients that have a GI obstruction or perforation and are complaining of abdominal pain, because you don't want to mask symptoms of a true obstruction by giving them these types of medications to relieve the pain, and really we're hiding what's really truly causing the pain or making the situation. So we will want to be cautious with that. Interactions that you will see with these types of meds. So it does reduce or increase the absorption of different drugs. So depending on which pH the drug needs in order to be able to be metabolized by the gut. It's going, if you're neutralizing that hydrochloric acid and you're neutralizing the acid in your stomach, your pH is going to change. So if your pH gets to a point where it's either too high for the drugs to work, then it's going to reduce the absorption, or it might increase the absorption if it's at a different range. So those interactions you need to look at. It does chemically inactivate certain drugs, so it will bind to certain drugs, these meds, so it replaces the meds, so it doesn't let the meds actually work at all, because it will bind to them, it will chemically inactivate them. The aluminum binds to the phenytoin, so that's something that you have to remember. So when it binds to phenytoin, it will not let phenytoin work. So patients that are on this medication don't want, these are not patients that you would want them to be taking these types of meds with aluminum. They all bind to tetracycline, so they will decrease the absorption of the tetracycline, and then so ultimately decrease its efficacy. So you don't want patients that are taking tetracycline to be using these basic compounds. Decrease the quinolones absorption by as much as 50%, and that's very important to know, because patients that are on quinolones, it's going to decrease its absorption, so it's going to less of the drug is going to be absorbed, so the patient's not going to get the full dose of, or that they've been taking, or that they should be taking, because 50% of that isn't going to be absorbed at all. May promote dissolution of meds, so meds that are enteric-coated usually dissolve when in an alkalotic state, to protect the stomach from the medicine, especially in the small intestine. So these would prematurely then dissolve in the stomach rather than in the small intestines, which could have detrimental effects. So especially with the different type of meds, so we need to be cognitive of which meds absorb where in the gut, so that way if meds are now that we want to absorb in the small intestines are now absorbing in the stomach, they're not going to work as effectively as they would normally. Antacids still, so nursing considerations that we look at with antacids is assess the GI and cardiac function, because it can alter the electrolytes. So remember, so if your electrolytes are already altered or have issues with, because you have cardiac issues, then these meds are going to then alter them even more. So these are things that we as nurses have to look at. Labs that we want to monitor with these patients that are on these antacids: renal functions, sodium levels, calcium levels, magnesium levels, aluminum levels. All of these are going to be affected by the antacids. So we want to make sure that we're following up on those labs and making sure that those levels are within normal range. Other meds that we want to make sure that we're thinking about when we're dealing with these meds that patients are taking, meds that they're actually prescribed that will have some effect by taking the antacids, over-the-counter meds that they're taking, herbal or supplements that they're taking, due to the drug-to-drug interactions that some of them may have with the antacids. It's going to be recommended that they do take 1 to 2 hours after the antacid. So once the antacid has already peaked, then, or once their medication that they're prescribed has already peaked, then you take the antacid. So you don't want it to affect the absorption or the mechanism of the medication working. Aluminum-containing antacids is going to be specific for those patients with renal failure. Your only ones that you would use is the aluminum-containing antacids. So renal patients can't take the ones with magnesium or calcium, they should only be taking the ones with aluminum, where they will have the least amount of effect on them for those specific patients. So things that we teach our patients, again, don't take within 1 to 2 hours of other meds, so it won't affect the absorption, especially your fluoroquinolones are actually 6 hours before or 2 hours after. That's going to be important to remember. Take with at least 8 ounces of water. Don't take for a long period of time without medical attention, and report any severe or prolonged constipation or diarrhea, especially if they're black tarry stools, increased abdominal pain, abdominal distension, nausea, vomiting, and hematemesis, and more serious signs and symptoms that need to be reported are going to be included in these. So you really need to make sure that patients know when to notify their physician that they're having these issues. Then you have H2 receptor antagonists, and these are your meds that end in tidine. So your cimetidine, your retidine, your famotidine, and your nizatidine. So all meds that end in tidine are going to be your H2 receptor antagonist. The way these work is that they do reduce but do not completely abolish the acid secretion, because it only works on the histamine receptors. So remember back when we talked about those 3 receptors that your gastric so remember, the histamine is your produced by your parietal cells, and so these H2 receptor antagonists are only going to affect the histamine production. So those are going to be specific to just histamine. So they will block the H2 receptor of the parietal cell. So why we take them? Indications, again, prophylaxis for stress ulcers, especially those critically ill patients, patients that have gastric or duodenal ulcers, patients with hypersecretory conditions, patients with aspiration pneumonitis, aspiration of something that causes inflammation of the lung tissue. So we want, because the histamine will have, we're blocking the histamine, it will reduce the inflammation. Patients with heartburn or acid indigestion, diagnoses like GERD, adverse effects that you will see from these meds. Cimetidine will have blocked androgen receptors. That will decrease the libido. Patients might have the gynecomastia, might suffer from impotence. They also might end up with CNS effects, so you might see symptoms like lethargy and depression, confusion. Usually we'll see it more in older adults with renal or hepatic dysfunction, because they're going to be more prone to getting this as a sign of toxicity or as a sign of an adverse effect. Retidine usually causes constipation, diarrhea, and nausea, and the famotidine will cause dizziness, drowsiness, and constipation. So you want to avoid tasks that require alertness with the famotidine. So you want to educate your patient to make sure they're taking them at night rather than during the day when they need to be alert. Contraindications, again, caution those at risk for pneumonia, patients with COPD. This will affect them because it decreases the acid, which helps to promote bacterial colonization of the gastric and respiratory tract. So it puts them at increased risk of having issues. Also caution with older adults because again of those anti-adrenergic effects, such as like impotence or CNS effects, which leads to confusion. So with older patients, if they're already confused, it might mask some adverse effects of these medications. So in the interactions that you might see as well with other meds, so your cimetidine can increase levels of your warfarin, your phenytoin, your theophylline, and your lidocaine. So if patients are on cimetidine and also on these medications, it will increase those levels in the circulation. It may inhibit the absorption of drugs that do require acidic environment. Again, because if you're reducing the acid environment, then the drugs that use an acid environment to be able to be metabolized will not be absorbed at the same rate. Smoking will decrease the effectiveness of H2 antagonists. So smokers are warned about this, so it will decrease the effectiveness. So these meds may not work as effectively on smokers. And then antacids do decrease the absorption of H2 antagonist. So if you're taking an antacid along with an H2 antagonist, it's going to decrease its absorption of it. So you need to make sure that patients are aware of combining the two because one will decrease the effect of the other. Nursing considerations, renal and liver function is something that you need to look at with your patients. Neuro, patients that already have a decreased level of consciousness because of the potential for confusion and disorientation with these meds. And again, patients with GI, you want to do a GI assessment on your patients, monitoring for GI bleeding, and making sure that your patients are not having symptoms. Administration, so how do we take these drugs? Cimetidine, you're going to take it with the meals. Your famotidine, you're going to take with or without meals. It doesn't really make a difference. Patients that are in the hospital setting will get it IV. It's a rapid infusion. However, when we give it, if giving it too fast can cause hypotension, so we want to give it as a slower infusion rather than a rapid infusion. Things that you want to teach your patients, again, avoid foods that promote gastric acid secretion, caffeinated beverages, coffee, decaf, alcohol. You want to make sure that these foods are avoided when you're taking your H2 receptor antagonist. Avoid aspirin or NSAIDs. NSAIDs will increase the GI irritation. So if you're on an H2 receptor antagonist, you don't want to also be taking the NSAIDs. It will make the GI irritation worse. Again, smoking decreases the effectiveness of these drugs, so smoking cessation should be promoted. Potential adverse effects, let them know. You want to teach your patient and educate them about the adverse effects that they can potentially be getting by taking these meds. You don't want them taking the ranitidine for more than 2 weeks, I guess. Again, unless it's prescribed for a long term. If they're getting it over the counter, you don't want them taking it for more than 2 weeks without getting checked out by a physician. Most of them you want to take at bedtime. And again, notify your prescriber if you have any signs and symptoms of GI bleeding. So coffee ground emesis, things like that are going to be your evident signs. So then we have your proton pump inhibitors. These are meds that end in prazole. So your suffix of prazole are your proton pump inhibitors, like your lansoprazole, your omeprazole, your rapiprazole, pantoprazole, and your esomeprazole. omeprazole. These are more powerful than your H2 antagonist. The way these meds work, they actually bind to the proton pump, so it's going to prevent the movement of your hydrochloric acid ions out of the parietal cells. So it's going to prevent your hydrogen ions out of the parietal cells, and it's going to block all gastric acid secretions. Indications why you take these meds, again, for gastric and duodenal ulcers, for erosive esophagitis, patients with GERD, patients with hypersecretory conditions. Usually these meds are used in combination with antibiotics in order to treat H. pylori. And in your Lewis book on page 913, you'll see this being talked about, and you'll see the history about this, why we would give it, and also your ATI says also used in combination with your H2 antagonist. So sometimes they give them in combination in order to be able to treat the H. pylori. So different combinations can be used as well. Adverse effects that you see with your proton pump inhibitors, they may predispose the patient to a GI infection because it greatly reduces the acidity, which the acid in your stomach is what keeps the bacteria at bay. So if you're greatly reducing that acidity, it will lead and predispose your patients to a GI infection. Short-term use that you might see, adverse effects are going to be headaches and diarrhea, some nausea and vomiting. Patients might complain of. Patients that are on this for a long-term use, again, predispose patients to GI infections. So because it increases the pH, it does allow the bacteria to grow. Patients on long-term use also might see osteoporosis or fractures. It decreases the acid, which may speed up bone mineral loss or decrease the absorption of other minerals. Studies do show that these results with those that have been on these meds for more than 7 years or for 7 years and up can cause, for long-term use, can also cause pneumonia. Again, decreased acid, increased bacteria. It increases the risk of pneumonia. And also with long-term use, you might see rebound acid hypersecretion because they've been on it for so long, your body will rebound from the effects. FDA issued warnings that you do see high doses of PPIs are associated with C. diff, pneumonia, and depletion of magnesium. So patients are at risk for wrist, hip, spine fractures, acroleurhydria, all FDA issued warnings that we do see with the PPIs. Contraindications, who do we don't give these meds to? We don't give it to women who are lactating, clients that are at risk for pneumonia or that have COPD, and we take extra caution with patients that have dysphagia or liver disease with these patients. In interactions that we might see, so physical interference with the absorption of other drugs, we're going to note that it may decrease your anticoagulation effects of your clopidogrel, like your Plavix. A pH aggregate inhibitor, studies do not show an increase in cardiovascular events. So even though it may have an interaction, studies really haven't shown a correlation with increasing cardiovascular events on these meds. Nursing considerations that we want to look at is assess your swallowing, because it can be a pretty large pill. So you want to make sure that patients can swallow them. You want to make sure you know your patient's history of GI infections or osteoporosis. If you're giving these meds IV, you want to make sure your patient doesn't have thrombophlebitis already, and you want to monitor the IV sites for redness, swelling, and local pain. Nasogastric, some granulars may be too big to go through a nasogastric tube, so you want to use you want to make sure that it says that their nasogastric tube is at least 16 French, and you want to be able to give on an empty stomach, which will help with the absorption of these meds. Patient teaching, things that we want to teach our patients. So you want to make sure you're teaching them to take on an empty stomach or take prior to eating in the morning. You want to make sure you don't crush, chew, or break. These meds, they do have sustained release. They are sustained release capsules. So you want to take them whole. You want to avoid alcohol and NSAIDs. Again, they will irritate the GI. And you want to report any signs and symptoms of GI bleeding, especially your coffee ground emesis. Your other med, your sucralfate. Your sucralfate binds directly to the surface of the ulcer. So it's going to coat the inflamed tissue. It's going to create a protective barrier. So the tissue is protected from the acid and the pepsin. These effects are transient, so it sticks to the ulcer up to 6 hours, so you have to take it multiple times a day. The effects don't last all day. Indications why we give these meds, the sucralfate, patients with duodenal ulcers, patients with gastric ulcers, and patients with GERD. Adverse effects that you're going to see, constipation being the biggest. Educate your patient to increase fiber intake. Drink at least 1.5 liters of fluid a day. If not, if they don't have any specific restrictions due to cardiac issues. Again, interactions that you might see, physical interference with absorption of other drugs. So again, you want to make sure you take them you take these meds 2 hours before or after any other drugs in order to prevent this from happening, and 30 minutes with any antacids. Contraindications, patients we don't give it to, again, patients with chronic renal failure or chronic renal disease. They're going to be more prone to electrolyte dysfunctions. Nursing considerations, bowel patterns and sounds. You want to make sure you are assessing those aspects on your patients. How we give it, so it's best given 1 hour before meals and at bedtime. Remember, you have to take it multiple times a day, so it's about 6 hours. So you want to be able to give it about every 6 hours or so. Tablets may be broken or dissolved in water. They're not sustained release, so you can break them and dissolve them. But you do not want to chew them or crush the tablet without the water. So you want to be able to use the water as a medium in order to make sure that the medication is well absorbed. Patient teaching, take other drugs at least 2 hours before or after the sucralfate, and complete the entire course of treatment. Allow enough time for your tissue to heal, so you want to take them for the entire time that you're on the med. Misoprostol. Misoprostol is a prostaglandin. The way misoprostol works is prostaglandin E analog. It acts as an endogenous prostaglandin in the GI tract. Prostaglandins help to protect the mucosa. So it decreases the gastric acid secretion. It will increase secretions of mucus and bicarbonate, and it protects the inflamed tissue. Maintains mucosal blood flow, so it's going to help to promote vasodilation itself. Reasons why we give misoprostol: again, patients taking long-term NSAID therapy, giving them this protective coating will help the NSAID irritation. Adverse effects that you might see: dysmenorrhea, which are painful menstrual cramps, or vaginal bleeding, which will lead to spotting. And then misoprostol since it is a prostaglandin, we also use it as a cervical ripening medication. It's used to induce labor. Patients must have a negative pregnancy test in order to take this, because we actually use it to promote labor on patients that are pregnant. So if we're taking them and they're not pregnant, we need to make sure that that pregnancy test is negative 2 weeks prior to actually initiating therapy, and then begin therapy on the second and third day of the menstrual cycle, which will then help also to cause cervical ripening. Contraindications, again, on patients who are pregnant, it will induce abortion or induce labor. So we use misoprostol as a labor induction, especially for OB. But if your patient is early and you're taking this medication, it will induce an abortion. So it is labeled as a contraindication. Patient teaching, again, you want to teach your patients to take these with meals and at bedtime, and take for the entire duration of the NSAID therapy. So if they're taking high doses of NSAIDs for a certain period of time, you want them to take the misoprostol in conjunction with that and for the entire duration. Simeficone's mechanism of action, it causes large gas bubbles to break into smaller ones, so they're able to be released. It will decrease, it's used to decrease in pain from the gas. So pain is from the big gas bubbles that patients get. So the simethicone, as it breaks down the gas bubbles into smaller ones, the pain that the gas produces will be decreased. Facilitates the expulsion of gas via the mouth of the rectum, so it will cause the patient to pass gas both orally and rectally. And you want to be able to teach your patients to take after meals and at bedtime. Chew your tablets thoroughly, or shake suspension well. So if it is a suspension, you want to make sure they mix the medication really well, and chew the tablets completely. Chew it so that they're completely broken down, not just chew it once and swallow. You want to make sure that you're chewing it, the entire tablet. So key points on patient teachings for these types of medications. Again, you want to teach your patients to maintain a daily journal. Will help to identify precipitating or alleviating factors, especially when they're on these types of medications. You want them to know when they need to report to their physician. So any severe or prolonged constipation or diarrhea, any increase in abdominal pain, any abdominal distension or nausea and vomiting, hematemesis or black Tory stools, all of those things are things that they need to report to their physicians. If they're taking it for GERD or hyperacidity, you want them to know to avoid black pepper, avoid caffeinated beverages, avoid alcohol or harsh spices, or extremes in food temperature. All of these will aggravate it further. So to allow the medications to do their job and the symptoms to be improved, you don't want them to be taking these things in continuation, and then they're just going to aggravate it further. H. pylori, if they're taking it for H. pylori, take each drug exactly as prescribed. Those combinations for H. pylori have been found to be able to eradicate the H. pylori completely. If you don't take it as prescribed, it will most likely reoccur. Key points that you want to remember: H2 blockers block about 90% of the acid secretion, and they only block the histamine receptors. The PPIs block completely 100% of acid secretion, so they're much stronger than your H2 blockers. Cautious use of antacids in patients with cardiac conditions. So you want to make sure that you are watching your patients that have cardiac issues while they're taking these types of meds, because of the potential for the electrolyte imbalance that it can occur. And again, all other meds should be avoided within 1 to 2 hours of taking your antacid, because it will affect the absorption. And these are your resources. Okay, and I hope you enjoyed this class.